is Lena Reichenberg with USA Physicians Group. Welcome to our Facebook Live chat with Dr. Richard Marks. We're thrilled to have him here today. I wanted to give you a little bit more information about Dr. Marks. Dr. Marks is professor and chair of orthopedic surgery at the University of South Alabama, and he also serves as a foot and ankle specialist with USA Physicians Group. Prior to joining the USA College of Medicine faculty, he served as professor of orthopedic surgery at the Medical College of Wisconsin, and he's been with us since November of this last year, right?
That's correct.
Yeah. He has dedicated his career to developing expertise on the treatment of sports injuries of the foot and ankle, Achilles tendon disorders, ankle replacement surgery, neuropathic disorders, and he also conducts extensive research in all of these areas. I would like to thank Dr. Marks for joining us today to talk about innovative treatments for common foot and ankle conditions. It's a pleasure to have you here today. And before we start, I just wanted to remind everybody that if you can please share and like this conversation as we go through. We want to get this message out to as many people as we can, so we really appreciate you sharing it. And also, if you have any questions, please feel free to post them in the comment section. But please also remember that Dr. Marks cannot comment on any specific medical cases, just conditions in general due to privacy laws. All right, so to start us off, I would like to, the first question, we mentioned that one of your specialty is ankle replacement surgery. Who would be a candidate for that?
Well, ideally, it would be an individual in their late 40s or above who would want to enjoy an active lifestyle, but would be willing to give up high-impact activities such as running, jumping off of high surfaces. What we found with the newer generation of ankle replacements is we're able to restore almost normal motion, and we have seen normal gait patterns that arise after the replacement versus ankle fusion. And this translates to better patient satisfaction, better outcomes, and if you look at this from outcomes scores, the outcomes scores for replacement are much higher than ankle fusion.
Very good. We got a question from Tracy, and she was wondering what causes cysts in ankle bones. Talk about the ankle.
Excellent question. So cysts in ankle bones are typically found on radiographs that we would obtain for any ankle disorder, and they can be multifactorial. So in some cases of just run-of-the-mill degenerative arthritis, you can see an inflammatory reaction which causes the cysts. We can also, if we do see a cyst, we rule out any inflammatory conditions such as rheumatoid arthritis or gout. So when we see those, this typically will have us order some additional blood work to determine what the causative factor is.
Yeah. And how do you treat arthritis in the foot?
Well, so if we were dealing with, say, arthritis of the ankle or any other portion of the foot, initially we always try conservative measures, whether it's immobilization, an anti-inflammatory agent, and in some cases physical therapy. If there's a good response to that, then patients can go along with a custom molded orthotic, which is an insert in a shoe or a brace. If that's not successful, then we need to sit down and talk about the surgical options.
Okay. And I know surgery sounds scary to some people, but I imagine that there are actually some things that we can do when, for example, working out or playing sports. We're here in the South Alabama football field house today on campus. And so do you have any tips on how to prevent injuries?
Well, certainly before anybody embarks on an exercise program, it's wise, particularly if there are any medical conditions, to consult with either their healthcare professional or a trainer at their local gym. And what we all need to remember is that we don't go from 0 to 60 in 2 seconds. You have to understand what are your goals for your workout program, and then how do you achieve them over a period of weeks and months. So I would never embark on a running program and try to run a half marathon or a marathon. That's just begging for problems. Probably the best advice would be to consult with a sports or healthcare professional to get that proper training program.
Good. And how important is physical therapy in that process?
Quite important. So we typically will make use of physical therapists for recuperation from an acute or chronic injury. The vast majority of the post-surgical patients that we treat will be enrolled in physical therapy. The therapists are another set of eyes and ears. They will help us set parameters for recuperation so patients can get their best possible outcome with their surgical intervention.
Great. Let's talk about some other common conditions. We had a question from Susan, and she was wondering if there have been any innovations been in the past for treatments of Achilles fasciitis.
So there's Achilles tendonitis, which would involve the lower part. We can see this of the calf muscle here. So the Achilles tendon inserts on the heel, and then the plantar fascia takes its origin on the undersurface of the heel bone or the calcaneus. In reality, they're very much interconnected. So some of the more recent treatments that have been effective. Let's start with heel pain. Plantar fasciitis, startup pain in the morning. Patients also are told they have a heel spur. This is an overuse condition. Can also be associated with date of birth. And so as we mature, tissues get a little bit tighter, and the plantar fascia is one of the worst areas where we'll see that tightness. So typically we will just start with, it sounds so simple, a stretching program, and that, however, gets about 90% of people better. There are newer technologies where we can actually withdraw blood, spin that down, and that's called PRP, and inject that in the injured site, which has shown regenerative capabilities, particularly for plantar fasciitis. From a surgical standpoint, there are some minimally invasive techniques that can be utilized, but again, probably the best treatment is a stretching program. When we're dealing with the Achilles tendon, so the calf musculature comes down and inserts on the superior aspect of the calcaneus bone. There are some innovative stretching programs. One is called eccentric strengthening, which was popularized in Europe about a decade ago, which has shown comparable results with surgical treatment. For Achilles tendon ruptures, we're able to do these now through a micro-invasive technique, either utilizing simple sutures or a suture device. That and what is called functional rehabilitation, which allows early range of motion and early weight bearing with the Achilles repair, is probably one of the most innovative things that we've been able to employ over the last decade. And what we know is tendons heal much better if there's some early motion. If we do this in a protected fashion, then those patients tend to do much better.
Good. Would that also expedite the recovery process after surgery?
Most certainly. And whereas in olden days patients were immobilized and off-weighted, we're now able to get them back in the gym in just a matter of a few weeks.
Oh, wow.
Under protection, and this is where a physical therapist or an athletic trainer comes in really handy.
Great. We just got a question in from Mona here in Mobile, and she's wondering, because we talked about ankle replacements, are ankle replacements really better than ankle fusions? Can you maybe talk about the difference of the two a little bit more?
That's a fantastic question. The historically, ankle replacements were initially put in the mid to late 70s. The first and second generations were not good. The newer generations, which spare bone and preserve the soft tissue architecture, have really become the gold standard. If you have a comparable patient population, my ankle replacement patients do better than ankle fusion patients. Now, having said that, patients that are too young, grossly overweight, have poor soft tissues, or have poor sensation in their limb will not do well with a replacement, and they tend to do well with a fusion. But and we've had the ability to look at patients in the gait lab, and the gait of a patient that's undergone a successful replacement actually is equivalent to a normal gait pattern, whereas you don't see that with the ankle fusion. But again, not everybody's a good candidate for a replacement. That needs to be carefully selected.
Mm-hmm. Great. Thank you so much, Mona, for that great question. You also, like, one of your major one of your interests in your work is also the joint preservation of the great toe. Can you talk a little bit more about that, and what are the benefits of that?
Well, so joint preserving procedures would consist of either a decompression of the joint, where we would take and maybe I could use, so what we're talking about is the first metatarsophalangeal joint, and with arthritis, a bone spur occurs on the top part of the joint, mm-hmm. which prevents normal motion. If that goes on to full-blown arthritis, then any motion in the joint is painful. So traditionally, once that, what we call end-stage arthritis has occurred, the traditional treatment was fusion of the joint. That leads to obviously a stiff big toe, and that prevents normal gait pattern. Yeah. So patients have a hard time walking at a fast clip or running with that type of procedure. The joint preservation techniques would consist either of simply decompressing the bone spur, or more recently what we've been doing is a resurfacing of the arthritic metatarsal head. So we take out the arthritic material, ream that down with a special instrument, and then actually put on a metallic cap on that arthritic bone. And what that does is that allows us to preserve the range of motion of that mm-hmm. joint. The secondary benefit of that is if that patient goes on to develop more global arthritis, that can be removed and the joint can be fused as a secondary procedure. So for someone that's interested in remaining active with walking, women that want to wear a bit of a heel, mm-hmm. Or otherwise, patients that just don't desire a fusion or solidifying that joint, the metatarsal resurfacing has really been a big boon to my practice.
Yeah. Speaking of heels, when we think about fashion, like that's a question for all the ladies. When we think about fashion versus function, how bad are high heels actually for your feet?
Well, they make your calves look thinner and
yeah, there are
taller,
some benefits,
and there are
right?
a lot of benefits for everybody involved, I think. I would say that success in life is moderation. So I wouldn't live in a 4-inch heel all day, every day. Mm-hmm. At the same time, heel wear can be quite acceptable. Women have to understand, however, that with the position that your foot is put in a downward position, the calf musculature can tend to tighten up. And so the secondary downfall from a heel would be a calf muscle that is tight, so you may need to stretch out a little bit more. Mm-hmm. And women can, on occasion, also develop pain underneath the ball of the foot called metatarsalgia. So with a with the heel up and the ball of the foot down, you're just putting more pressure under the metatarsal heads. So again, everything in moderation.
Good. Well, so we're about 15 minutes into the conversation. I just wanted to remind everybody, if you have any more questions, keep them coming, and we'll go through them one by one. Actually, Katrina had a really good one that I just wanted to point out. With all the cutting-edge technology happening every day, what is the average downtime after a bunion removal surgery? So
again,
excellent bunion.
Excellent topic. So bunions are deviation of the great toe joint. So there's angulation, and what we see is the bump on the inner aspect of the shoe. So shoe wear is a causative factor. We always need to have that conversation with patients when they develop a bunion. And then there's a subset of patients that this is inherited, so we call that familial in nature. With more modern fixation techniques and the tendency to do less invasive procedures from a surgical incision standpoint, we're able to get patients up on their feet a bit earlier, but unfortunately, you still need to protect that operated area for about 6 weeks or so as the bone heals up. And this depends on the type of procedure that is performed. But what I counsel my patients is expect some form of, immobilization for 6 to 7 weeks, physical therapy after that. By about 12 weeks, most patients should be back into normal shoe wear, and you're paying a lot of time up front, but if this is done well and there's a good recuperation, that bunion repair should last for the rest of your lifetime.
Oh, great.
And I would love to be able to honestly offer patients a quick, mini-invasive technique that would allow them to start running at 2 weeks. The biology of bone and soft tissue just doesn't allow that. So I think better to be conservative up front so that you have that good, long-lasting result.
Good. And speaking of bunions, Katrina had another question. Has there been, that feeds into plastic surgery of the feet again, has there been any further advancements towards plastic surgery for the feet aside from a bunionectomy and toe realignment?
And this is a debated topic. I typically will counsel patients, if you have a painless deformity that doesn't affect your function, it's probably best to leave it alone. We frown upon doing those procedures simply for cosmetic purposes, but if there is a deformed toe, such as a hammer toe, and what we see here is an excellent example of a hammer toe, the bony prominence rugs on the top of shoe wear. Those are reliably fixed by removing bone and straightening out the toe, but we frown from doing that simply for cosmetic purposes. And some patients will ask, well, can you shorten my toe or lengthen my toe? There are some circles where it has been suggested that you can inject filler in the sole of the foot to create more of a fat pad. That's typically frowned upon, and from a scientific standpoint, doesn't have a great track record. So I would caution any patient to stay away from doing any procedure strictly for cosmetic purposes.
Well, in light of the opioid crisis, pain management is another hot topic. So from your career perspective, I know you've done a lot of research and you are doing a lot of innovations in the treatment of common conditions. What are the top treatment innovations in pain management that you've seen in your career so far?
That's an excellent topic. The opioid epidemic, is first and foremost on everybody's mind. We strive to limit opioid use post-surgically to as small a time frame as possible, and typically will not prescribe narcotics for patients with a chronic arthritic condition. Some patients will benefit from the use of what we call a multimodal approach with the use of Tylenol, an anti-inflammatory agent. There are some nerve-mediating agents that are quite effective, but probably the best recent innovation is one by which we are able to work in conjunction with the anesthesiologists and preoperatively perform a blockade of the nerves, either at the level of the ankle or higher up at the knee or the hip. And what this allows us to do is, with long-standing anesthetic agents, patients can get up to 72 hours worth of almost complete pain relief, and they can be discharged with a pain pack pump after their surgical procedure. So this obviously lessens the use of opioids in the postoperative period. What we found is that this is wonderfully accepted by patients, and for my practices led to much higher patient satisfaction. We've just started at USA a multidisciplinary approach to this in conjunction with the Department of Anesthesia and orthopedic surgery and general surgery, offering these blocks to our patients. And I believe it's probably the only program in the area that is doing this in such a fashion.
Yeah, absolutely. That's great. Speaking about pain, when exercising, is there actually like good versus bad pain? Is there actually something like good pain? When is it good to push through pain, maybe?
Typically, if you're experiencing pain in the midst of an athletic event or a workout, and that is becoming more magnified, that's probably your body's way of saying, you know, maybe you're overdoing it. It's not uncommon to have muscular pain after a strenuous workout, and that's the body's reaction to the stresses from the workout. As long as that is dissipating within 24 to 36 hours, that's your body saying, hey, you have stressed me and I'm trying to repair itself. If that pain continues for days at end, then either there's been an acute injury or the workout routine is improper, and that's when it's probably wise to contact a musculoskeletal health professional to see what's going on. So if you're a bit fatigued after a workout, that's a good thing. But if that prevents you from getting off of the sofa that evening or the next day, you may have overdone it.
Yeah, that's good. Good information for all the athletes out there. Diane from Priola would like to hear more about fallen arches, and maybe you can also talk about high arches, if those are a problem.
Sure. Probably fallen arches or flat foot are more common than a high arched foot. Fallen arches can be as a result of just hereditary factors, so children that have naturally flat feet. As we mature a bit, this can be due to either arthritic conditions or tendon dysfunction. And the one tendon that attaches on the inner aspect of the foot is called the posterior tibial tendon. That helps to create the arch. If that is injured or degenerated, that can lead to arch sag, and then the end result of that would be arthritis. So the initial treatment for that is typically immobilization and the institution of an arch support in the form of an orthotic or insert. If that's not successful, then reconstruction of the arch and the tendon would be warranted. And those patients with an extremely high arch, they tend to be more prone to overuse injuries on the outer aspect of their foot and can experience stress fractures of their fifth metatarsal or repeated ankle sprains. So in those conditions, it's resting that injured part and either helping to realign the arch with the insert or surgical reconstruction.
Okay, good. We had another question from Mona. She was wondering if you had seen any data on using stem cells to treat Achilles tendonitis.
And I had alluded to the use of plasma-rich protein for the plantar fasciitis. Stem cell treatment is akin to PRP, is starting to be used for Achilles tendon injuries. The initial data is encouraging. There's not a large amount of data to support that. It's probably been more successful in the treatment of knee arthritis more than anything else, but I think what we're going to see in upcoming years is allowing patients' own bodies to heal themselves, which is essentially that. You're taking stem cells, whether it's from the iliac crest or the calcaneus or withdrawing blood from patients, spinning that down and then re-injecting it. I love the concept of really being able to heal yourself.
Yeah, it's very impressive. It's great. So we have about 5 more minutes left. If you have any more questions, now is a good time to share those with us. Just comment in the comment section. And Christina was actually wondering what can help nerve damage after an ankle fracture. Sorry.
So one has to determine what was the cause of the nerve damage. Was it the fracture itself? Was it if surgery was required, is a nerve damage inadvertently during surgery? And then in some patients that have, whether it's a fracture or a bad sprain, they can develop what is called chronic regional pain syndrome, where there's uncommon hypersensitivity about the foot and ankle. So nerve damage that is caused as a direct result of an injury, we typically will attempt to allow that to settle down and heal itself. If there is nerve entrapment in a surgical scar, then there's an attempt to either mobilize that nerve through physical therapy and treatment with medications. In some cases, it's necessary to go in and release or remove that portion of damaged nerve. In the cases of patients with chronic regional pain syndrome, which was also previously known as reflex sympathetic dystrophy, you will see after a bad sprain or a fracture, hypersensitivity. So patients will not tolerate anything touching the skin. It can become red, warm, shiny, and those are patients that we like to see almost emergently, and we will get them in a pain program where there are special injections that can be and medications that can be used for that. So a number of different causative factors, and if there is nerve damage after an injury, always wise to have that looked at. Typically that can be helped.
Good. Speaking of about nerve damage, I noticed that some people are popping their joints, not only on the feet, but like on the hands or something. Is that actually harmful? Can it be harmful?
It's probably more annoying to people that are sitting next to the individual that's cracking their knuckles. Typically, though, that won't cause any arthritic conditions. What you're doing is you're basically relieving pressure in the joint.
Good. That's good to know. Well, Brittany from Mobile was wondering whether research indicates bone spurs are hereditary, particularly in the feet and heels.
They can be both hereditary, so there are some families that just love to create bone as a result of normal stresses in the bone. And my family, unfortunately, we're bone spur formers, I hate to say. So there can be a hereditary component, And then there can also be a component of overuse, or a bone spur is basically the body's attempt at repairing a soft tissue injury where the soft tissue attaches to the bone. And instead of healing the soft tissue, this calcium deposit or bone spur is formed. So typically that's as a result of overuse of that one region.
Good. Anne had a question about how to best treat a recurring stress fracture.
So first and foremost, if we see a patient with stress fractures, what was the cause of that? And it's amazing how many patients have a low vitamin D level. So we will immediately look at vitamin D levels. Bone density studies can be quite helpful. We also will look at the possibility of thyroid dysfunction as a causative factor for stress fractures. Smoking can also weaken bones, so that's part of our patient intake. So it's whenever we see a patient with a stress fracture, we strive to determine what was the cause of that. Just the body mechanics and the way that the foot, in my case, the way that the foot is shaped can also lead to that. We talk about high arches leading to stress fractures. So is this a mechanical problem or is this more of a biologic problem? So and we strive to determine what the causative factor is.
Great. That's a very good question. So I think we've got time for one more question. Let me just put this up here again. Debbie had another question, but we already talked about plantar fasciitis, and she was just wondering how to help plantar fasciitis, but I mean, you've touched base on that.
First and foremost, stretching. The heel can be protected with a spongy insert. In more refractory cases, we may need to place patients in a removable boot brace to quiet that down. Physical therapy is an excellent adjunct to help stretch out the tissues and use ultrasound or other modalities. But the most cost-effective form of treatment is an organized stretching program.
Good. Well, that was definitely a lot of great information for us, a very informative session. So thank you once again, Dr. Marks. Before we finish, I would like to thank everybody watching, and also, we'll be sharing this conversation on our Facebook page so that you can share it with a friend or someone you know. And we'd also like to invite you to 2 upcoming events. We're here in the football field house, and the South Alabama Jaguars are actually just getting ready for their spring game, which is coming up on Saturday, April 14th at Lad People Stadium, and that's going to be at noon. And that's going to be the iHeartRadio Red versus Blue scrimmage. And then just before the game, on that same day, the University of South Alabama College of Medicine, the students, the medical students, will be hosting their Gumbo Chili Showdown beginning at 10 a.m. And you can find all the information about those games on their Facebook page, which is at facebook.com/USA College of Med. So check it out. Advance tickets are just $8 or $10 on the day. And children under the age of 10 are actually free, so it's going to be a great outing for the entire family. So thank you once again for joining us today. It was a pleasure to have Dr. Marks here. Thank you again for your time.
Thank you very much.
And I hope everybody has a great and pleasant rest of the week. Thank you.